Welcome back, my Psychians, for Module 71, which will cover behavioral, cognitive, and group therapy talk. So let's get started. So when we think of behavioral therapy, it is within the lens of actions, right? Observable actions, how things are connected together, and behavioral therapy. So make sure on the top of your little screen right here, make sure you write that there is a connection to our operant and classical conditioning chapter. So behavioral therapies, their ideology is this. They do not seek to explain psychological disorders by exploring the unconscious, right? So they do not focus on the mind, right? So behavioral therapy is all action-based, right? So they don't focus on the mind, that's more cognitive, right? So we assume that a disordered behavior is learned either through operant or classical conditioning, right? We either learn to associate to stimuli, which could be a phobia, can start inducing phobias, right? Or every time we're stressed, we then want to relieve the stress, right? By adding, maybe start smoking, right? So that's more on the operant conditionings, our rewards and our consequences, right? So when we think of symptom relief, it can be achieved by changing the rewards and punishments, which are influencing problematic behaviors, so operant conditioning. And we can do this by building new associations of two stimuli, which connect to phobias or panic through another different automatic response, right? So classical conditioning can also help us, condition our they can condition our initial responses into a different conditioned response, right? So again, operant and classical conditioning, very, very backbone-ish of behavioral therapies, okay? So let's first start talking about counterconditioning, and this is a vocab term that this is all under the behavioral therapy umbrella, so make sure it's under the same part of your notes. So counterconditioning is based on the principles of classical conditioning. And what counterconditioning is a process or a procedure that conditions new responses to stimuli that trigger unwanted behaviors, right? So essentially, it's almost very similar to a math problem, right? So when we first look at counterconditioning, it was kind of explored by Mary Jones in a way to extinguish fearful behavior. So when we see if someone is fearful of social settings, right, how can we condition new responses that will not trigger anxiety with social responses, right? So it's adding in different stimuli to connect them together so there's no longer that anxiety-induced actions, right? And then we have something called exposure therapy. Anyone remember little Albert who was classically conditioned to fear white fluffy bunnies and animals? Yeah. So if little Albert, no one thought that little Albert would need some exposure therapy after he was conditioned to fear white rabbits, and then it turned into generalization of bigger animals. And anyway, it's a form of counterconditioning. So exposure therapy falls under counterconditioning, and it's used especially to treat phobias. And there's something that's called, there it is. Yep. So real quick, exposure therapy, the definition is in yellow. It's emotion arousing stimuli. It's an emotion arousing stimulus that is confronted directly and repeatedly, ultimately leading to the decrease of emotional response. So for example, if an example of exposure therapy, which also falls under systematic desensitization, it's a type of exposure therapy technique. So we have exposure therapy, and then the systematic desensitization is the technique used. And so, for example, systematic desensitization would be when we progressively combine the fearful-inducing stimuli to gradually eliminate the triggering of the unwanted arousal. So how they would do this is, little Albert's scared of white bunnies, right? So we would put little Albert in a room with a white bunny on both far sides of the end, and day by day, we would slowly bring them together, and little Albert will hopefully start to associate a calm feeling with being in the room with the bunny. And so you're starting to create a different connection, right, to the stimuli instead of the anxiety arousing one, right? So for example, if Miss H has a phobia of needles, which I do, my friends, my first step would be just looking at a needle. And oh my God, I'm already thinking about sweating. But yeah, so again, but baby steps, think of baby steps to desensitize, okay? Desensitize us, okay? Okay, and then we have aversion therapy. And so right next to aversion therapy, I want you guys to put classical conditioning. So, oh gosh, aversion therapy. So let's talk about it. It's a form of counterconditioning used especially to treat unwanted habits or harmful behaviors. This is an example of people who have an alcohol problem. And this is a classical conditioning experiment that can possibly have you connect alcohol with unwanted stimuli. So aversion is when we have an unwanted state that is associated with a behavior, which will gradually replace it so it will stop. So for example, someone who has a problem with drinking, right? They drink too much. So what is going to be introduced is a nausea drug, okay, a nausea drug. So unconditioned stimulus, if we take the drug, our unconditioned response would be nausea, right? So it's a reaction that happens. So now what they're going to do is they're going to put the nausea medication into the alcohol, connecting to stimuli, nausea and drinking alcohol, which will create nausea. After repeated usage, every time you take a drink of alcohol, you feel nauseous, you're slowly going to associate alcohol with nausea, which will, right when you even think about it or when you maybe want to drink some, it will create the conditioned response of nausea, and it will hopefully deter you from craving the need of alcohol, right? So how cool is that? Classical conditioning at work, my friends, and how it kind of can change our behaviors, right? Okay, and remember, classical conditioning, involuntary, right? So they don't have a choice to feel nausea or not, right? Okay, and then we have our operant conditioning side. So within the operant conditioning lens, it's the behavior that is shaped and maintained by consequences, right? So this is all voluntary. This is reward-based and consequence-based. It is not involuntary actions. This usually involves the use of positive and negative reinforcement, right? So taking something away, giving something in, right? The positive, negative, a little bit of a learning review. Because reinforcement is most effective at changing behavior than punishment. Remember, punishment stops behavior, but we want to use negative and positive reinforcement to get to our desired behavior. So for example, and we use this a lot for example, my friends, there's something called a token economy, which is what therapists create, where a patient exchanges a token for some sort of earned desired behavior or reward. You see it in parenting with chores and allowance, but also they use it in AA when they give people chips of sobriety. It is a token economy. It's something that you were given as a reward to keep your behavior of sobriety going. A token economy, right? Which falls under operant conditioning. So now I want you guys to do a little scribble, and we are going to move into cognitive therapies, okay? Cognitive therapies, all within the brain, my friends. Cognitive therapy is a very major therapy, or remember it was about, cognitive therapy was about, I think, 16% of the pie of all the therapies. It is very, very common with depression, anxiety, eating disorders, anything that has illogical thought processes happening in the brain, right? So let's talk about it. So, and let me move my little picture. Let me get rid of it real quick so you guys can see. Okay, so based on the assumption that, it's a psychological problem, especially depression and anxiety, and this is where there is a result of illogical thought patterns of thinking called irrational beliefs and cognitive distortions. Treatment techniques focus on recognizing and altering these unhealthy patterns. So when we also talk about the biomedical side, if someone has an extreme prolonged, so again, there's a spectrum of how much people feel anxiety or depression, but if it is dysfunctional enough or distressful enough, remember the 3Ds, medication can also be used within these therapy realms. So don't forget that just because someone's in cognitive therapy, that doesn't mean they can't have biomedical therapy. There could be a combination of both, okay? And this is where Beck's cognitive therapy comes in, and we really want to know Beck, okay? So Beck's cognitive therapy, as it is in a nutshell, depressed people tend to distort experiences, like mundane experiences, and they maintain negative views of themselves, and they also miss their kind of illogical thinkers when it comes to negative experiences and what they mean. So when maybe Sally wasn't invited to a party or whatever, she will think kind of very illogically different drastically, while someone else will maybe have the coping skills to be like, oh, I didn't want to go, and it's, whatever, I have this or this. So therapy challenges when it comes to cognitive distortions, it's an all or nothing thinking, everything's a catastrophe, discounting the positive, and they tend to overgeneralize. So if they tend to say, if someone says something rude to them, they say, oh, he doesn't like me, everyone doesn't like me in that group, right? So they tend to overgeneralize. And treatment focuses on clients recognizing their automatic negative thoughts and beliefs, how A gets to B gets to C in our thought processes, right? So again, clients are then directed to empirically test whether these beliefs are true, and coming to a realization of their unnatural and unrealistic thoughts. But again, where some people can say, oh, well, obviously that's a logical thought pattern. But my friends, when you're having those thought patterns, it's very hard for you to recognize them, right? It might be easier for people outside your world to recognize them, but it's hard to recognize them yourself because it's your mind, right? It's the way you think. So again, this is Beck's cognitive therapy. And there's something that's called Rational-Emotive therapy. And what Ellis's Rational-Emotive therapy is when negative emotions arise from people's irrational interpretations of experiences and their negative beliefs, okay? So Rational-Emotive therapy. So the therapists help the clients recognize, again, there's that keyword, recognize their irrational beliefs and firmly challenge their clients to develop more positive, realistic views. And after seeing that irrational beliefs are unreasonable and they are emotionally harmful, right? So when we look at here, I pulled this from your book, but there's two pathways. So someone who is struggling with emotive, so people who are struggling with either depression or anxiety, and they have these illogical thought patterns. So this is an example. So they lost the job. Their internal belief would be, I'm worthless, I'm hopeless. That's what's happening within the brain, which leads to depression. Our thoughts lead to actions and outcomes, right? And so, but let's take another viewpoint. Someone who does not have maybe irrational interpretations or experiences, people who may not struggle with depression, this is maybe how they would look at it. Loss of job, internal beliefs. It wasn't a good fit. I deserve something better. So staying on the different, kind of being more rational about it, right? Which leads to a lack thereof or less than, a little bit less depression, right? So it's the changing of the internal beliefs, how A gets to B gets to C. Okay, so it's kind of like the cornerstone of cognitive therapy. All right. And now we have CBT, cognitive behavioral therapy. Yes, it is a certain type of eclectic therapy, right? Because it combines multiple together, but cognitive behavioral therapy is one of the most used and most common for people to attend. And I also believe insurances cover more cognitive behavioral therapy stuff. So I believe insurances choose it as well. So cognitive behavioral therapy is exactly what you think it is. It's a mixture of cognitive therapy and behavioral therapy. And in my own personal opinion, from everything I've learned from, studying psych for the past 5 years, this one, it kind of takes the cake because it deals with both our mind and our actions, right? So it aims not only to alter the way we think, but also the way we act. And a really great example is so people who struggle with OCD, obsessive compulsive, remember our obsessions are within the brain, but our compulsions are our actions. So you can see how cognitive behavioral therapy would be much better than just behavioral therapy or cognitive therapy, because the actions and the ideas and the thoughts, they all are together. They're all connected. So this seeks to make people aware of irrational negative thinking and also the behaviors that are related to it, right? And it also is used to practice the new thinking and behaviors in everyday settings. Often described as problem-focused, action-oriented, right? And so another example would be, someone who is a CBT therapist, someone who has OCD, we might challenge them to go into a public restroom and maybe, visit it 3 times a week. So again, connecting the thought processes that you'll be okay if you go in there and working on the behavior aspect, they work together, right? They work together. And then we have group therapy. So a few things about group therapy. It's used for certain things, right? So group therapy is good for people who have survived a trauma, people who want to come together in solidarity. Group members can benefit from knowing others that are similar problems, right? So again, remember, AA is where people just go and share their experiences and they're not alone with their struggles. Family therapy considers the family as an interdependent system and seeks to help each kind of member understand his or her role in the family. So, family therapy is a group therapy. Couples or marriage therapy. I know there's a program at Sonoma State, MFT, so marriage family therapy therapists, marriage family therapists. So I know they have an MFT program along with their counseling program. So different schools have different programs that they specialize in, and it's designed to foster communication. We also have members of self-help groups, just like I say, help support groups. So these all fall under group therapy. And so the percentage of improvement of people who go to therapy helps, my friends. Being there to talk to someone, therapy has had really strong outcomes. And so both clients and clinicians report high effective rates of treatment when it comes to therapy. Research has consistently found that psychotherapy is significantly more effective than receiving no treatment at all. Okay, so it's almost like therapy, it couldn't do any harm, right? And it's also, therapy is most effective when the problem is clear-cut and specific. So some factors that contribute to the effectiveness of psychotherapy is quality of therapeutic relationship. You want to pick someone that you have a connection with. A lot of people recommend that you kind of surf around to find a therapist that you connect well with. You don't want to have a therapist that you're kind of standoffish with. Sometimes people really care about gender, so you might want to have a female therapist or a male therapist. Again, things to think about. You want to have a caring, empathetic, responsive, trained therapist, motivated, optimistic clients, supportive family and stable living situation, along with a culturally sensitive therapist, which if that, needs to happen, and that's a big part of it, that totally can also be a factor. And just, this is our last slide, but just a few things to know about kind of the culture and values of psychotherapy. Psychotherapists may differ from each other and their clients and their personal beliefs, values, and cultural backgrounds, which is, again, why you really want to move around and see who you connect with. Clients sometimes have trouble relating to therapists with different cultural backgrounds. So remember, individualistic versus collective cultures, that could be different. And people from minority populations tend to seek out therapy less than people who are white. It is a very strong statistic. And just like we talked about, there's a lot of cultural things going on, right? Who believes in what's going on in different cultures. Some people who have schizophrenia or think they are shamans in other cultures. So again, cultural sensitivity. Therapists feel, and again, a lot of people struggle with trying to find therapy because, my friends, it is so expensive, or just have the lack of resources and the money. And, I know Kaiser's kind of, well, from what I've heard, it can take months to get in. And, yeah, and also if you don't get along with your therapist, it does lead to heavier dropout. Some people don't believe that they can change therapists, right? So again, these are just some little kind of wrapping the bow of our little psychotherapy conversation. So that is the end of this second lecture, and our next video will be on the biomedical side. So stay tuned.